coronaviruses that have been beta coronaviruses that have caused severe disease, and this is now particularly in many places such as the United States and South America. There are three coronaviruses. This is the first time we've had a pandemic, obviously, but both SARS and MERS were very similar diseases in some ways, at least in terms of the kind of infection that they caused. Like the others, the ACE2 receptor is used by the virus to enter the cells, and the ubiquity of the ACE2 receptor on both epithelial and endothelial cells is responsible for the systemic effects of this disease. And so the distribution of these receptors in lung, GI tract, and kidney explains some of the, and as well as brain endothelium, produces much of the multi-organ response. However, it's also true that the disease causes a systemic inflammatory response, is sometimes referred to as a cytokine storm. And even though the average patient may not have even as much inflammatory response as we might see with bacterial septic shock, there are subsets of patients, maybe as many as 15 to 20%, who have very significant inflammatory response. And this is some of the early reports out of China, where you see, particularly in non-survivors, large increases of inflammatory cytokines, of molecules such as serum ferritin, which are very potent markers of inflammation, as well as coagulation abnormalities as measured here by D-dimers. Some of the syndrome is reminiscent of the kind of macrophage activation syndrome or atypical HLH that occurs with viral disease. And so this is not just hyperinflammation and that you would see with an inflammatory response to infection, but actually suppression of natural killer cell function, which causes the syndrome to become really out of control. So it's really important to understand that this is not simply lots of inflammation caused by lots of infected cells, but it's also an immune dysregulation that occurs that results in sort of runaway inflammation. And there are criteria that have been published looking at categorization of macrophage activation syndrome or atypical HLH that can be useful to guide you in selecting patients that may have this runaway inflammatory response as opposed to simply a bad local response. And the criteria generally include things like persistent fever, hepatosplenomegaly, cytopenia, high ferritin levels, hypertriglyceridemia, reduced ferritin, or perhaps increased D-dimers, some liver function abnormalities. And then in the unusual event that we obtain a bone marrow biopsy, we see hemophagocytosis. There's extremely high mortality in this subgroup of patients. And the question, therefore, is raised as to whether a specific response to this form of COVID-19 would be appropriate. Novel therapies for the disease that have been shown to produce some efficacy is remdesivir, a recent positive phase 3 trial. However, there's limited, if any, benefit in severely ill patients. And then most recently, steroids trial of dexamethasone showed a very remarkable 30% decrease in mortality in patients requiring mechanical ventilation, a lower effect size in less severe ill patients, but even some benefit to those. There's a variety of other therapies that have been put forth as potentially useful, but there are no other established therapies, drug therapies for this disease. Experimental therapies that are out there are targeting the inflammatory response, and they include drugs like anakinra, which is an anti-IL-1 or anti-IL-6 therapy. But here we're going to talk about another approach, a broad spectrum approach to modulate the inflammatory response by removing a variety of inflammatory molecules to restore homeostasis. The current evidence for use of blood purification in its various forms is still small. We know that standard CRT is not effective for this kind of cytokine storm. Plasma exchange has been used, but has its own complications. And today we're going to talk about the use of hemoperfusion. This has been looked at in a variety of other forms of macrophage activation syndrome, where therapies traditionally have been really quite toxic. Drugs like anakinra and cyclosporin, etoposide, and so really the question is there a role for hemoperfusion in cytokine activation syndrome like we see with COVID-19? And indeed, we had a recent our first virtual ADKI, which was conducted over the last couple of weeks, last few weeks, and the results of this ADKI on COVID-19 and acute kidney injury, which included a section on the use of hemoperfusion for management of COVID-19, will be published in the next a month or two, we hope. This is our faculty photo on Zoom with people appropriately social distancing. This is just one of the figures from that paper that describes how one would utilize or think about hemoperfusion for this disease process. And you can see that the use of these therapies to remove a variety of different molecules in the pathophysiology of severe COVID-19 infection. And then some very practical advice about the types of hemoperfusion and other forms of blood purification that could be utilized, the targets that would be sought to remove, the duration of therapy, frequency, anticoagulation, blood flows, etc., are discussed. These figures will be available shortly on the website and then ultimately in the publication. So with that, I thank you for your attention for this quick introduction, and we're going to move to a series of very brief 10-minute discussions, and then we're going to move to a moderated discussion moderated by Claudio Ronco. So we're going to start with Alex Kirsten from Aachen. Alex is the director of the cardiac and pulmonary ICU at the University of Hospital in Aachen, Germany. Alex, please. Alex, you're still on mute.
Oh, I'm still muted. Now better. Okay. These are my conflicts of interest, and even though I work with Jaffron, none of which I'm going to say has any tainting or whatsoever. This is the agenda, just a quick look into our local setting and background, and then how did we treat SARS-CoV-2, COVID-19 with hemoperfusion in some of the patients in our center. To start, where am I? I'm actually sitting in my office, and as you can see, there's a map of Germany, and I'm located right here where the arrow points to the basically most western corner of Germany, right bordering the Netherlands and Belgium. And if you zoom into that on the right-hand side here, you can see this is a region composed of Aachen as the main city, and here in dark blue, that was a localized region with the largest and initial outbreak of SARS-CoV-2 in Germany. And this is where most of the patients we treated came from. How many patients and what population are we talking about? We are talking about a population of roughly 800,000 people living in this green area. we had 3,952 cases up till last Friday, and around 162 dead. So we're far from an outbreak, as you might have seen in other areas of Germany, other areas of Europe, like northern Italy or Madrid or New York in the US. However, this has been one of Germany's most severe hotspots. How did we prepare for that? We had some heads up, of course, from China and from Lombardy. This is our baseline. Basically, we are a large tertiary care center. We have 111 ICU beds where we can treat basically ventilated patients altogether. 12 of those beds are cardiology, pneumology in normal situations. 25 beds are post-operative critical care. Then there's some GI and general internal medicine. And then there's a specialized neurologic critical care unit. Also, we have roughly 30 step-down beds. We increased that since March. We doubled our cardiology pneumology capacity, and we also increased the post-op ICUs to 125 beds. So I think we were reasonably prepared. We stayed on the same level of step-down beds. And by doing so, we never came into a situation where we had to triage a patient because of shortage of beds. So I think we did fine. And basically, we tried to do something that our colleagues from Italy always say was their main goal, and I think that's a very good goal. We try to maintain ICU capacity for every patient who needs an ICU bed, regardless whether they were SARS-CoV-2 positive or negative. And we thought a lot about what things do we actually do, and what things can we do, and what are we good at. And these are the things we do standardized. Of course, we treated potential superinfection. We tried to hemodynamically optimize our patients. We tried protective invasive mechanical ventilation, ARDS therapy, multiple organ support. And then there are a lot of things we do in a tertiary care center in special indications, like right heart failure, we do PACs. But we also, and this is the main topic of this talk, we do extracorporeal cytokine absorption hemoperfusion. And usually we look at cytokines before we decide whether a patient is suitable for that. So we measure IL-6 regularly. We also measure soluble IL-2 and TNF-alpha. You can see there are a lot of other things we thought about, the problems, and you're probably all aware since you've been treating the same kind of patients with the same kind of syndrome. We thought about things we did not want to do. So we never treated with hydroxychloroquine. We did not treat with lopinavir, ritonavir, or camostat mesylate. We did not do inhaled interferon or heparins. We thought about trials. We actually took part in the early registry for remdesivir. We did not take part in any other trial for steroids, convalescent plasma, or so forth. And I think final words on all of this have not been spoken. So these are the initial 126 patients we treated. And you can see we had 59 patients in the ICU. Mean age is roughly around mid-60s, with a trend to being slightly older if you were treated on a ward. These are the typical patients, the ones you see all around the world getting sick in Western civilization with pre-existing diseases, which it's the normal kind of patient group you would expect. However, if we look at the patients I've treated here and we've treated here, there is a selection bias. Most of the critically ill patients, roughly 2/3, were actually transferred from other centers, from smaller local hospitals, while most of the patients we treated on the wards were mainly admitted from our emergency department. So we have a bias towards selecting sicker patients in our ICU as we are a tertiary care center. However, if you look at these patients, they do fit what you see from other centers. Symptom onset to intubation is roughly 10 days. These patients are on almost all on invasive ventilation. Some of them go on to ECMO, and around 30% of them die within the hospital, or 35% die within the hospital. This is data. Some of them were still, when we made this graph or made this table, some of them were still hospitalized. As of today, there's only 2 patients left hospitalized in the ICU, and there are none left on the wards. So how did we do hemoperfusion in these patients? And we did it the same way we did it before COVID-19. Patients we put on hemoperfusion usually end up with a Jafron HA380 cartridge. And these are patients that are either on ECMO, and then we put it in parallel to the oxygenator, or they're on CRRT, which is CVVDH in our center, and then we put it in line with the dialysis membrane, usually upstream, and we use regional citrate anticoagulation as a standard. However, in COVID-19, our standard, after I think the first week or first 2 weeks of treating and conferring with other centers in Germany, we decided to put all patients were COVID-19 patients who were critically ill on ICU on unfractionated heparin and titrate that to a APDT of 45 to 50 seconds. So these patients had all systemic anticoagulation to some degree. Oops. Backwards there. Regarding hemoperfusion, which patients did we treat? Well, we only treated patients if the patient was on invasive mechanical ventilation. Why did we do that? Well, there was only one patient really who was managed without IMV on the ICU due to a DNR/DNI order. All the others were ventilated. So there was not really the question whether I want to hemoperfuse a patient who's not on invasive mechanical ventilation. We also did it only if the patient was on CRRT or ECMO. That being said, it's mainly because we don't do a lot of standalone hemoperfusion at our center. We are very experienced in hooking it up to the CRRT device. We only have 2 doctors who actually are able to do the hemoperfusion on a hemoperfusion standalone device. So it's a kind of a triage thing, and we were not really able to do that broadly. Also, there's always the question, if your patient's not sick enough and there's not enough organ failure, does he really need hemoperfusion? That's maybe something to be discussed. The patients we actually treated all had or should have had an IL-6 above 1,000. That's the cutoff we have thought of after looking at previous trials that have been done, and that we feel comfortable with saying, well, there is excessive cytokine release, and those are the patients we are targeting. And altogether, out of the 59 patients who were critically ill, 12 qualified, if we use this kind of term. 7 actually were on ECMO on CRRT, and 5 patients of these 12 died. What happened when we put them on hemoperfusion? Well, the IL-6 drops, and so that works, obviously, it's what we want. We measure IL-6 daily in most of our patients, every time 3 o'clock, that's when the blood samples are drawn, and then at 7 in the morning I have my measurements. And you can see the patients here. This is survivors before and after hemoperfusion. They had quite high IL-6 levels. There's one who was actually below 1,000, but everybody was above. And everybody drops in their systemic IL-6. And this is the same to most regard for patients who ended up dying. They also have an initial drop in IL-6, and some show a slight or more pronounced rebound. We only did hemoperfusion once for 12 hours. So we did not feel comfortable enough in these patients to do repetitive hemoperfusion. And also to be honest, we didn't really see the need, because IL-6 dropped, and obviously dropped almost equally in survivors and dead. And all patients actually improved initially. They all got better hemodynamically. They all got better in regards to their PF ratio. However, that is, of course, confounded by others' treatment. We didn't just do hemoperfusion alone. We have resuscitation therapies if the patients are in shock. We optimize their right ventricle and their pulmonary vascular resistance if they have acute cor pulmonale. We give them inhaled nitric oxide. We do anti-infective therapy. We prone our patients. We do neuromuscular blockade if we think that increases compliance. And some patients were actually on ECMO. So a lot of confounders in this setting by which patients might get better within the initial treatment. And so we left it at treating them once for 12 hours. So in summary, in this very small sample of patients, hemoperfusion in our center in critically ill COVID-19 patients was feasible. And we did it on CRRT and ECMO. We did not see anything out of the ordinary with these patients that we would not have expected. And despite selection of sicker patients, As I said, most of the patients were transferred to our center because they were too sick to be treated at a regional hospital level. Only 20% of our patients qualified for hemoperfusion if we use our standard of indication, and yours might, of course, differ. Our numbers are way too small, and the course of the ICU treatment is way too long in these patients to infer on any effects on outcome markers. Just to make one point, the ICU length of stay median in this patient group was 28 days. So doing something in the initial treatment for 12 hours, I'm not very sure. I'm not quite confident that we can see any signal after 2 or 3 months of hospital stay. And with this, I would like to give go back to John Kellum. Thank you.
Thank you, Alex. Thank you very much. We're going to move quickly. Our next speaker is Ricard Ferrer from Spain. He's the president of the Spanish Society of Intensive Care and the head of the ICU at Vall d'Hebron University Hospital. Welcome, Ricard.
Thank you, John, for this nice presentation. I'm going to share also my experience here in Vall d'Hebron in Barcelona, and also the experience we had during these days with perfusion in these patients. So I would say that the main feeling during the pandemic is uncertainty. So you can see this picture of the Barcelona streets completely empty of people because the lockdown that we didn't know for how much time and what is going to be the extent of this catastrophe, and this is of course difference of other catastrophes that maybe we know a little bit better the schedule. In this case, we have been with uncertainty for many days and weeks, and also there is some uncertainty, of course, because it's a new illness about the efficacy of different treatments we have. So the ICU mortality in several studies is around 25%, and the main drivers of this outcome is ICU organization, virulence and viral load, host response to infection, and maybe some impact of treatments. That is what we are going to discuss today. So this is the extent of the outbreak in my hospital. We have single patients at the beginning of March, and the peak was 2 weeks after the lockdown with 24 patients in the ICU per day. That leads to the maximum capacity of the ICU with 170 patients at the same time at the beginning of April. That means that it's 300% of the basal capacity of the ICU. Also for ECMO, we have 9 patients at the same time, with 20 patients needing ECMO support. So that means that if you have the organizational capacity to expand the ICU and to provide enough ventilators and ECMO machines and ECMO filters during this outbreak, then you will have an issue of mortality. So the first point is about organizational issue. Our mortality below 60 years is around 3–4%, and then it increased obviously after 60 years to 35 and 50% in patients above 70 years. So globally, the mortality is around 17%, with quite long mean ICU stay. So after organizational, maybe we have to look to the virus. There are 2 main strains, and the main one, which is type L strain, is more aggressive than type S, and also the viral load. The viral load is also an important determinant. There are at least 2 studies showing that the higher the viral load, the higher it's going to be the severity and the mortality. And the other factor is the host response to these infections. Dr. Kellum has discussed during the introduction that there are some patients with an adaptive immune response with not a severe increase in biomarkers of inflammation, but there are this subgroup of patients with this syndrome that has been described during the introduction, which is called also a cytokine storm. and trying to modulate this inflammatory response would play a role in the treatment of this condition. Which patients develop this syndrome is something that is still under discussion, but probably like in sepsis, patients with some degree of chronic endothelial dysfunction because age, but also because diabetes, hypertension, obesity, probably this is playing a role because these are the main factors also for this severe condition. So those patients who have this preconditioned endothelium are probably able to generate this dysregulated host response to this viral infection. This is playing a role, and also the genetic background. We could contribute with some of our patients to this analysis, and we've shown that there are several polymorphisms in some genes in chromosome 3 and genes in chromosome 9 that are risk factors for developing severe forms of COVID-19 pneumonia. So the role that are those genes playing is still a little bit under discussion. So in chromosome 3, those genes have a relation with the way that the virus enter into the cells, and in chromosome 9 in forms of activation of coagulation. So this is something that we have to discuss a little bit more. And also in relation with this dysregulated inflammatory response is the possibility of bacterial superinfections. So bacterial co-infection is unusual, but bacterial superinfection could be frequent in our patients. We had 251 patients in mechanical ventilation, 99, so close to 40% of them develop BAP, and mainly by gram-negative bacilli. So this is also playing a role, and the main risk factors for developing this BAP are related with some of the compounds we are giving to patients trying to modulate the inflammatory response, like steroids and tocilizumab. So those treatments have several of these drawbacks as major risk of developing BAP. Depending on those factors, patients are going to develop several degrees of organ dysfunction, mainly, of course, RDS in the ICU needing mechanical ventilation. So the treatments we have a combination. We are using combination of therapies that are mainly supportive, but also the antivirals that has been also described before, and some of these strategies trying to immunomodulate the patient. Regarding AKI and needing of a continuous renal replacement therapy, we have 20 patients. So this is 6.6. Some of the observational studies, the registries, were informing that maybe this is a higher rate. In our case, we have 6.6. So in our contingency plans, we have estimated that we are going to need bigger numbers of hemodialysis monitors, but it was not the case. We can manage with our usual equipment because we have only 20 patients spread during these 2-month periods of the outbreak. So those patients have 64 years mean, and mainly men, and with the risk factors we have discussed, like hypertension, diabetes, obesity, etc. So half of these patients were on ECMO. So half of them, this is an important data, Pacheco score 12 at ICU admission, and so far at ICU admission it was around 6 points, but at the moment of the starting CCBH it was around. Most of the inflammatory mediators and the markers of coagulation, of course, are increased in this population. This is something that is known. and those patients are going to be have been in continuous hemofiltration during 3-4 days, and we have some problems with dysfunction of the catheters, and mainly the main problems were related to anticoagulation, because this is a condition that is an important procoagulant state. So in 25% of the patients, we have to use systemic anticoagulation. Mortality is 35%, mainly because urinary failure or refractory hypoxemia. We select also some patients for hemoperfusion. In this case, the criteria we used were IL-6 above 1,000, D-dimer above 1,500, and ferritin above 500, together with a severe acute respiratory failure. The main problems, again, are coagulations of the circuits, and sometimes levels of IL-6 difficult to interpret, because many patients receive tocilizumab before ICU admission, and then it's difficult to interpret the levels of IL-6 after giving the antibiotic, because it's a peak. There's a peak after administering the monoclonal antibody, and then this has some difficulties. So at the end, we're 7 cases, 6 male and 1 female. Mean age is 56 years. In these patients, all of them are in severe acute respiratory failure, 2 requiring ECMO. So far, as I said, at ICU admission, it's 5, mainly because of respiratory failure, and levels of IL-6 at admission is 1,500, and levels of D-dimer are also quite high. 4 patients have been treated with tocilizumab and 3 with steroids. So that means that previous attempts to control the inflammatory response have failed. So I think this is an interesting point, to use hemoperfusion as a rescue therapy of patients not responding to some other pharmacological approach. Usually we treat the patients maybe a little bit late, 8 days after ICU admission. Mean so far at the moment of the hemoperfusion is 9, and 2 of them had PAP also at the moment of the hemoperfusion. So we have a nice decrease in the most important biomarkers before and after the therapy, and some improvements in lung function. Of course, these are mean values. Mortality close to 1/3 of the patient. So the key learning points are that this infection is a devastating condition. So RDS is the main important organ dysfunction, but sometimes we have AKI and cardiovascular dysfunction together with the RTS. Bacterial co-infection is uncommon, but some patients, up to 40%, could have bacterial superinfection, mainly by gram-negative bacilli. I have some concern about the liberal use of some medications, especially anti-IL-6 monoclonal antibodies and steroids. I think we have to go for a more personalized approach, using this information we have about a lot of biomarkers we have been testing during this outbreak. Other complications are unexpected, like some have some tracheal perforation. Some of these PAP were necrotizing pneumonia going with emphysema, and several cases of pulmonary embolisms that I didn't have time to discuss. And this dysregulation of the inflammatory response could be a target for blood purification in this patient. I would like to finish saying thank you to the coordinators of this, at the end, 13 ICUs we had during the outbreak in my hospital, and just a reminder about the use of masks following months if we want to avoid further outbreak. Thank you for the attention.
Thank you very much, Ricard. We're going to move on quickly to our next speaker. We're going to move from Spain to Turkey, where Professor Dilek Kazancı will speak to us. She is the Associate Professor of Anesthesiology and Reanimation, and director of the General Critical Care Unit in Cardiovascular Disease Hospital in Ankara City in Turkey.
Hello from Turkey, and here is the capital city, Ankara, and I'm attending you with from the Ankara City Hospital, which is the biggest complex, medical complex in Turkey. And hello to all audiences, all speakers, and dear moderators, and thanks for this nice and kind invitation by Jeffron. I want to talk about our hemoperfusion experiences and some with special cases and COVID-19 patients. As you know, sepsis is an exaggerated response of the organism to the infectious agents, which is characterized with overproduction of cytokines, and main problem is the increased mortality in intensive care patients. When we go to septic shock from the sepsis, despite appropriate fluid treatment, we can see the development of persistent hypotension. Despite effective source control, we can see cytokine storms, and increased vasodilatation can cause vasopressor need, and bad renal function actually rapidly goes to acute renal failure, so we need to hemodialysis or CRRT possibilities, and hemodynamic monitoring goes to best situation, unstable hemodynamic state occurs. Cytokine release syndrome is a systemic inflammatory response that can be caused by infection, some drugs, and other factors, characterized by a sharp increase in the level of large number of pro-inflammatory cytokines. And interleukin-6 is the major component of the cytokine storm, is an important member of cytokine network and plays a central role in acute inflammation. Interleukin-6 is a multifunctional cytokine and that plays an important role in human metabolism, in disease control, and autoimmune cell differentiation. When we come to cytokines, and they are diverse group of small proteins that are secreted by cells for the purpose of intercellular signaling and communication. Specific cytokines have autocrine, paracrine, and endocrine effects. Sorry. What do we understand when it comes to hemoperfusion? We understand actually the removing of the drugs by passing the blood from the patient through an absorbent material and back to the patient. Also some molecules which have greater affinity for the materials which is inserted in the cartridges will be removed by this hemoperfusion process. Absorption has been proposed as a third mechanism for solute removal from the circulation. Sorbents prepared in specific cartridges and can be placed in direct contact with blood or with plasma. New hemoperfusion solutions for systemic inflammation decreases cytokine levels in different percentages according to molecular sizes and severity of the disease. In our last 20 months experience, also included in COVID-19 patients, we made about CRRT to 89%. We use extracorporeal organ support therapies in 71 patients. We have used sometimes with CRRT and ECMO, extracorporeal organ supports, and but our mortality when we use these devices is about 50%. I want to talk about one case, intra-abdominal sepsis, non-COVID intra-abdominal sepsis. He has an emergency surgery because of intra-abdominal abscess. After intubation, wide spectrum antibiotic therapy was started. Also, we started fluid therapy, and we started vasopressor support to this patient. But the liver enzymes and all the other parameters goes wrong, and we decided to make cytokine absorption. After the first cytokine absorption therapy, the vasopressor need was very decreased, and stabilization hemodynamic stabilization was occurred, and vasopressor need was completely diminished after 18 hours hemofiltration therapy. That takes about 58 hours postoperatively, and after second cytokine absorption procedure, we was at the 64 hour, we discharged patient from ICU. And here are the results of blood urea, creatinine, and AST LAT levels, other two stocking removal therapies. And the case 2 was a pneumosepsis. He had a chronic obstructive pulmonary disease and colon cancer and he had underwent a colon cancer surgery. At 6th day, postoperatively, sudden onset of deterioration in general status, high fever, tachycardia, and hypotension occurred. We saw infiltration in the inferior zone of the left lung in CT, and wide spectrum antibiotherapy was started. Vasopressor treatment was started. We decided to make cytokine hemoabsorption treatment, and at the first procedure after hemoabsorption, white blood cell count was decreased, and after 3 days of hemoabsorption procedure, the patient hemodynamic status and laboratory results were completely recovered, so we discharged the patient from ICU. The main thing I want to emphasize that after diagnosis of sepsis, appropriate antibiotherapy must be started in 1 hour. Fluid therapy must be given. If hypotension resists, vasoconstrictive agent is infused, mostly noradrenaline be used. Start time of the hemoperfusion is also important for the effectiveness of the procedure. And hemoperfusion performed in early period of septic shock have a good effect on hemodynamics, decreased vasopressor need in septic shock with multiple organ failure, and decreased mechanic ventilation time. In the context of sepsis, 2 small randomized control studies describe the effectiveness of HA330, decreasing inflammatory mediators, along with an improvement in hemodynamics and mortality and ICU length of stay. One of the trials was conducted in septic patients with acute lung injury, and in this study, there was marked improvement in respiratory parameters in the hemoperfusion group. A novel coronavirus was identified in late 2019 as the cause of cluster of pneumonia cases in Wuhan, China. It has since rapidly spread, resulting in a pandemic. And we had huge number of ICU patients due to this disease. And at the beginning, we had no exact antiviral therapy. So patients with COVID-19 disease has come us with fever, cough, myalgia, or fatigue or dyspnea, even acute respiratory distress syndrome, and acute cardiac injury and secondary infection. A lot of severe patients had to be admitted to intensive care units in our hospital. In Turkey, is about 5 to 18% of patients need ICU treatment in different regions of Turkey. And 67 of severely ill COVID-19 patients may present with additional organ dysfunction syndromes. Sepsis-like syndrome induced by high level of circulating cytokines. Acute kidney injury, heart and liver dysfunction occurs. Vasoconstrictor use is mostly due to sedation, need for mechanic ventilation therapy. That is the other phase of COVID-19 sepsis. 211 therapy is advised for COVID-19 stocking storm with HA330, and anticoagulant is heparin or citrate we use in our country. We can use it with compatible various purification devices like CRRT or ECMO, and the adsorbent inside the cartridges is neutral macroporous adsorption resin. I want to talk about our 4 patients with COVID, and we have good results in the first patient and the 4th patient, but second and third patient we haven't good results, and we all lost these patients, unfortunately. Case 1 was a 51 years old male patient. He has no comorbid diseases. 10 days ago, he attended another pandemic center with myalgia and fatigue. 2 PCR was negative, but thorax tomography was suspected, and he has hospitalized and get antiviral therapy for 5 days, and he discharged to home. After 10 days, He consulted our emergency service. He had myalgia, dyspnea, and loss of consciousness. In this case, we accepted him into ICU, and we have electively intubated him. His laboratory findings, as you see, was very bad. His pH was very low. He had great buzz excess. He has increased ferritin, troponin, procalcitonin, and CRP levels. His lymphocyte is about 300. His white blood cell count was about 50,000. And also he had bad cardiac function, and he has 2 positive PCR results. Here is his computed tomography screening, and we see in bilateral lungs widespread paving stone views, consolidation in posterior sections, air bronchograms, patchy consolidated areas in bilateral lower lobes. So we have decided he has ARDC. And in clinic monitoring, since he had a bad cardiac function, we have applied veno-arterial ECMO. Mechanic ventilation was continued. Also, intravenous immunoglobulin, favipiravir, and anakinra therapies were given to this patient. Inotropic support has started. At the 6th day, ACI was developed. Unfortunately, we have seen acidosis in the arterial blood gases. We also have some gram-positive coccobacilli in blood culture, so we started a wide spectrum antibiotics. And CRRT was started, and 2 times HA330 stocking filters was applied to the patient. Interleukin-6 level a bit decreased, but we lost these patients because of the ECMO-related hemorrhagic complications, unfortunately. And here is the X-ray findings before the therapy. Actually, at the first consulting to the hospital, and the last day X-ray finding of these patients. In case 2, where we are not very successful, I think the patient had many comorbidities. He had an uncontrolled diabetes mellitus, obstructive sleep apnea, gut, and hypertension. We planned hemoperfusion at the 5th day, and he had bad consciousness and developed acute kidney injury. This may be the key point. Serious comorbidities and late decision for hemoperfusion may have role in bad prognosis in these patients. In case 3, this patient was 74 years old. Her relatives were also COVID positive PCR. She had hypertension and hypothyroidism. She had bacterial infections in clinical follow-up and used multiple antibiotherapy. Old age may bring bad condition in COVID-related ARDC. So blood purification decreases pro-inflammatory and anti-inflammatory molecules, plasmatic concentrations during early sepsis, avoiding a toxic threshold to be reached, and thus limiting organ dysfunction. In our 4 cases, there may be some timing problems. All patients had anticoagulant therapy with low molecular weight heparin after COVID-19 diagnosis. We also use heparin anticoagulation in all cases during hemoperfusion therapies. We aim to remove cytokines in all 4 patients, also to improve hemodynamics and ventilation status. Our timing may be wrong. Additional bacterial infections deteriorated the clinical signs, and we need to detect best golden hour for these patients, I think. This is the last day's findings in COVID-19 disease in Turkey. We are trying to make everything good in our country and for our patients. I hope we will go to good days after this pandemic. Thank you very much.
Thank you very much, Professor Kazancı. We're going to move quickly to our next speaker. Eric Avesyan is a medical resident in cardiology at the National Medical Research Center in the Ministry of Healthcare in the Russian Federation. Welcome, Eric.
Thank you very much for the invitation to this very important conference. I had to say that in our everyday practice as cardiac intensive care unit, we had only been using a renal replacement therapy from a long list of extracorporeal hemoperfusion techniques. But to say for true bacterial infections and infectious complications. So in our patients were not so rare, and sepsis and septic shock, we had them from time to time. And now it's clear that this method, hemopurification with, for example, Jafron device, can be very useful in our usual work. But during COVID-19 pandemic, guided by our colleagues, we managed to perform fairly large number of procedures for us for 2 months of work, and we hope that in the future we will follow this path. The first case in Russia, the first positive test was made in January, and now we have almost 600,000 patients here in Russia. 2 months work with COVID-19 patients, 82 patients admitted in our intensive care unit, the third of them with severe cardiac comorbidities, and we performed we treated 8 patients with this extracorporeal hemiperfusion techniques by means of cytokine hemadsorption and selective plasma filtration. This is our local definition of COVID-associated cytokine release syndrome. It's based on the data available in the world and our own practice. As soon as cytokine release syndrome is diagnosed and initial treatment started, the severity of CRS is being assessed. For severe and patients with multi-organ dysfunction syndrome, we decide to provide this hemopurification techniques. We use a Jafron device for hemiperfusion and plasma filter Evacuate 2C. We believe that combination of these two methods in one procedure or one after another can bring a lot of benefits because of, first of all, more intensive purification during one procedure or one after another, as I said, or wider spectrum of removed molecules and the toxin removal, better removal of smaller molecules, for example, for the patients with kidney and liver failure. And we also think that it can be a base for more prolonged time of effective cartridge work. So as I said, the inclusion criteria for us was severe COVID-19 associated CRS when interleukin antagonists are ineffective or unavailable or contraindicated. We use that even without acute kidney injury and without the need of renal replacement therapy or ECMO. The parameters that we used for the assessment of the effects of these procedures, you can see on this slide. As I said, we treated 8 patients. In all patients, we have seen decreased cytokine levels after the procedure and during the follow-up. Positive clinical effect we have seen in 4 patients out of 8, and we have not seen any procedure-related complications. Here are basic characteristics of our patients. We separated them into 2 groups on the basis of the outcomes. 4 of our patients were successfully discharged from the hospital. 4 of them died during the ICU stay. As you can see in the survivor group, survivors were younger and they had fewer comorbidities. In most of our patients, we used interleukin antagonists. Respiratory support was as following. 3 of our patients were on invasive mechanical ventilation, but we also had patients on non-invasive ventilation and even on high-flow oxygenotherapy, high-flow ventilation. Vasopressors were used in 1 patient from each group. They were in septic shock, as you can see. Acute kidney injury and bacterial co-infections were not so rare. Here you can also see the procedures that we performed in our patients and the number of the procedures. made. We are familiar with the concept, with the recommendation that about the regimen of the procedure of the hemoperfusion 2+1+1, but because of some reasons, because of the shortage of devices and shortage of specialists in this from this area, we decided to be guided by the clinical and laboratory parameters when we were deciding the procedure to be done. And we're also trying to figure out the time frame from the beginning of CRS, COVID-associated CRS, to the initial initiation of extracorporeal technique. And of course, it's a retrospective analysis of limited patients, but we figured out that the time frame was shorter in survivors. And we also want to talk a little bit more about one of our patients. He is 50 years old, a male, and we want to point out to take a closer look to that when procedure is done is made early, it can have it can figure out more effective. The disease started as usual with a high fever and dry cough. On the 7th day of the disease, shortness of breath, tachypnea, the features of respiratory distress appeared, and then he was admitted to our ICU with a higher fever and with severe dyspnea. And we think that this rapid sudden deterioration in respiratory function can be interpreted as the beginning of CRS. Here is the CT scan. You can see a large areas of ground glass opacities and consolidations. On admission, his oxygen saturation was as low as 77% on ambient air. Tachypnea was observed with respiratory rate of 30 breaths per minute. ABG showed decompensated respiratory alkalosis. On a venous blood sample, you can see neutrophilic leukocytosis with absolute lymphocytopenia. CRP and procalcitonin were also high. The initial treatment was started with respiratory support by means of high flow ventilation with the following parameters, and medications were started as usual with antimicrobials because of the elevated RCT. Here you can see how things unfolded during his stay in our ICU department. On the 3rd day of stay in our department, basing on the very high level of ferritin, very high level of CRP, interleukin-6, increasing white blood cell count, and sustained fever, we decided to initiate hemopurification procedures. You can also see that he was, by that time, transferred to non-invasive ventilation. That means that his respiratory function deteriorated. So we started with selective plasma filtration because of the rising AST and creatinine levels, because of the multi-organ dysfunction, the early stages of multi-organ dysfunction syndrome. After that, the procedure lasted 5 hours. After that, we took a blood sample, and we had seen a decrease in pro-inflammatory markers and a little bit decrease in fever. After that, in a very short period of time between the procedures, we started hemoperfusion by means of cytokine absorption with the use of Gefron HA330. Procedure lasted 4 hours, and after that, after 1 or 2 hours before the procedure, we took the blood sample, and interleukin was, as you can see, 65, and CRP was going down, and AST creatinine was also started to decrease. and fever has gone. He was transferred to nasal cannula. After his stay in our hospital on the third day from the last procedure, he was transferred from ICU to the ward department, and on the 7th day he was weaned off from any respiratory support. On the 14th day he was discharged, and you can see the dynamics of the parameters. We believe that in this patient and in a couple of another patients who were suffering from CRS in the very beginning, the use of combined therapy, combined approach, resulted in better outcome and allowed us to avoid advanced multi-organ dysfunction and intubation with the transfer to invasive ventilation. So in conclusion, I'd like to point out the next statements. Hemoperfusion is an effective treatment modality, and it should be performed in patients with severe COVID-19, of course, and CRS. And as in our opinion, combination of cytokine hemoperfusion with selective plasma filtration has advantages in that it can provide more intensive cytokine removal, additional endotoxin removal, and metabolite removal in this group of patients. Early initiation is very important in our opinion, and can provide more benefits than when it's used as a salvage therapy, salvage strategy. Procedure-related complications were not seen in our 8 patients. So in conclusion, I'd like to say that this procedure, these techniques are very useful in our usual practice, even when we are working with our usual cardiac intensive care unit, and we will follow this path, and we will use these methods in the future. Thank you for your attention.
Thank you very much, Eric. For our last presentation will be given by 2 physicians from Pavia, Italy. Forenza Ferrari is the senior consultant at the first ICU, and Professor Mirko Baliato is the acting director of the second ICU at the IRCCS Policlinico San Matteo Hospital. Please, Ren.
Sorry. Okay. Thank you. Thank you for your invitation, dear colleagues. I'm glad for having joined this webinar, and I would like to thank Professor Ronco, Professor KELLUM, and Jaffron for this invitation. I please honored to have the opportunity to share with you my presentation. As all of you know, in Italy, in particular in my region, Lombardy, the COVID-19 outbreak has the worst rate of infection and mortality in Europe. And a terrible human tragedy and medical challenge found us unequipped to care for so many severely ill patients. Clearly, during pandemic, we couldn't carry on our research activity in a systematic way, as the clinical practice only on its own was extremely tough and overwhelming. At the moment, we are trying to grasp any useful information coming from the bedside in order to learn from this painful experience, gain more knowledge in case of a potential spread in the future. Okay, before the pandemic, we normally prescribed blood purification treatment like hemoperfusion in patients with cytokine storm due to sepsis, reperfusion damage, for example, in patients with refractory cardiac arrest needing the ECMO, or in hematologic patient after FCAR therapy or after bone marrow transplant. All patients admitting in our ICU with a diagnosis of RDS related to COVID-19 receive a standard therapy consisting in sedation, curarization, enteral nutrition, prone position, and in protective invasive mechanical ventilation set by transpulmonary pressure or PV tool measurement. Antibiotic prophylaxis with piperacillin, tazobactam, and azithromycin were prescribed in all patients for 5 days, and sulfametazole trimethoprim only in the patient with CD4 lymphocyte less than 100 cells per microliter. In addition, some patients have been recruited in different trials, receive either remdesivir or lopinavir ritonavir or convalescent plasma or tocilizumab. We conducted hemoperfusion with ECMO circuit. We put the arterial line after the pump and the return line before the pump. In this patient, we fit the cartridge directly in line with the ECMO without CRR. Inspired us to think a new studies with the aim of proving our hypothesis. Lymphocytopenia was characterized by an abnormal innate immune response. In conclusion, we speculated two indications for hemoperfusion. The first one, to modulate the imbalanced inflammatory response. And the second one, when the immune paralysis promotes co-infection of fungi or bacteria causing septic shock. We could decide the timing to start hemoperfusion based on some markers, procalcitonin or the beta-D-glucan in case of underlying cytokines level and the lymphocyte subset in all cases. Sorry for the problem. Thank you so much for your attention.
Thank you very much. Professor Bagliato, do you have some comments on this presentation?
Here we are, both. Okay, we can start with the discussion, Professor KELLUM.
Well, let me go ahead then and introduce Professor Claudio Ronco.
Okay.
No introduction, and he will moderate the discussion period. Professor Claudio Ronco is from the University of Padua and Vicenza, Italy. Claudio.
Also receiving some questions and answers that I would like immediately to address before coming to the conclusion. We don't have too much time, but one of the questions is, are there specific biomarkers or targets or endpoints that we should consider to define the efficacy of the therapy? I think that any of the speakers is entitled to give an opinion. Ferrer, maybe?
Yes.
Okay. In my slide, I show our idea. Our idea is to measure perfusion, the lymphocyte subset, and more cytokines, not only IL-6, because in our opinion, IL-10 is very important in order to, IL-10 could be, could have two, could have two functions. The first one limit the pro-inflammatory storm. The second one, if it is produced in a large amount, IL-10 can lead to immunoparalysis. So we did know now what is the cutoff that can discriminate restoring the immune system or lead to immunoparalysis. But IL-10 alone is not enough. IL-6 alone is not enough, but the ratio between IL-6 and the IL-10, or the ratio between IL-10 and the lymphocyte counts could be predictive and more informative than the cytokines alone.
If I may add something, I think what we studied was the expression of HLA-DR on monocytes, and this somehow describes a kind of restoration of the immunoresponse of the patient. Alexander, do you have a comment on these target molecules?
Yeah, I think your points are very well taken. I think just measuring one systemic marker of inflammation in any given patient is not going to help. And we've discussed this before, that it's the homeostasis of your immune response that is out of range. I find it difficult in my regular patients already. I find it more difficult in COVID-19, as we have no clue about the longitudinal course of the disease so far. I think we are quite unsure at what point of time we're actually catching our patient in our ICUs. Is it early? Is it late? Is he systemically ill through endotheliitis? Is he just locally sick because he has pulmonary vascular problems? So a systemic approach to a localized problem might not be the right course, because you have a lymphocytopenic patient and you're taking away necessary inflammatory response. So I find this very hard. I think looking at a more complete picture, what is pro-inflammatory increased, what is anti-inflammatory increased, and how are his immune cells actually reacting would be the most interesting part. And if we can't do that, I think looking, as you said, at monocytes.
If I can show this cartoon, I think it's important to describe exactly what the speaker have presented, the possibility that we have both pro and anti-inflammatory mediators, and the idea of using hemoperfusion is actually to cut the excess of either pro or anti-inflammatory mediators, somehow producing protection of the endothelium. One of the questions that has emerged from the Q&A group of the attendants is, in fact, how early should we intervene? I think we have different options, but the two differences are, should we use this as a rescue therapy, or should we use this as an elective and protective therapy? Ricardo, do you have a comment on this early versus more ahead on time?
Yes, I think organ dysfunction is critical. So it will be very difficult to select a population of patients that we use hemoperfusion just because we have a diagnostic approach, because several biomarkers are up and down. So I think that there is a lot of heterogeneity in that. You know very well that these cytokines have a kinetic that is short in time, and then it's difficult. And also you have the interaction with some of the medications that the patient may receive before, like steroids or monoclonal antibodies. So in our case, we prefer to wait a little bit until organ dysfunction is established, especially RDS.
Professor Kellum, you were chairing the ADKI consensus recently, and this is one of the figures that we have prepared all together. So is there any point in which you practically would you recommend to start with hemoperfusion?
I think that it's obviously the most important question that we're facing. Not every patient has an indication for this sort of therapy, but a large number of patients have what appears to be a systemic disease, not a disease that is limited to the pneumonia, but rather a systemic disease. And as you know, this disease is mediated by a variety of different mediators that are shown on this slide. So there's a potential for the blood purification techniques, including hemoperfusion, to modulate both inflammatory cytokines as well as removal of various DAMPs and PAMPs that have been into the circulation, which are causing injury to remote organs. So in my view, it's really a question about, can you identify patients who are manifesting a systemic disease? And the earliest you can identify those patients, the more likely you will be able to interdict this disease process with a extracorporeal support therapy, which, as you know, targets the plasma. This is not a drug that goes, into the tissues, but a process which unloads the circulation of the inflammatory response that's spilling over from the lung and other infected organs.
Yeah, to answer more questions that have come, in fact, whether the therapies can be combined. I think this figure that will soon appear on the paper from the ADKI consensus group shows clearly that in one side you have hyperinflammation, and the other you may have a superimposition of sepsis, and on the other axis you may have AKI. And the therapies, as you can see from the lines, they can be combined. So the use of macroporous polymer sorbent devices can actually use for hyperinflammation. Absorption in this condition is the main mechanism, and it can be combined with other type of therapy. People have asked about recommendation. I think that the recommendations are quite well described in this Lancet paper that we published recently, where basically we divide the situation in indications, preparation, prescription, delivery, and monitoring. In the phase of indication, as Professor Kellum says, identifying the right patient is the key issue. And there are specific patients that can be identified either because they are in a randomized control trial or because they are specific cases in which hyperinflammation seems to be the condition that dominates the clinical picture. And in these cases, there is a pathophysiological rationale for the use of hemoabsorption. But then you have to get prepared and you have to be able to deliver the therapy and know that how to make anticoagulation, how to practically treat the patient in this situation. Also, we have recently prioritized our research question because I think that this COVID-19 emergency has clarified that we are unprepared and we need to do more studies to clarify the feasibility, the utility, the efficacy, and to identify endpoints, which can be biological or they can be somehow clinical. At the end, because we don't have too much time, unfortunately, but I tried to combine the several questions that I found on the Q&A, I think as take-home messages, we can say that there is a pathophysiological rationale for the use of hemoperfusion in COVID-19 cases with cytokine-induced hyperinflammatory syndrome. One cytokine to target is not enough. More cytokines probably can be targeted in a specific way with hemoadsorption. Cytokines may be the target molecules as a preventing and protective treatment to avoid subsequent organ damage. The question will be, how early can we treat the patient, and what are the criteria to identify the patient? In practice, I think the criteria for indication and initiation are those patients who are not responding to therapy. They look as evolution, to have an evolution towards more severity. And then we need to do more studies to understand how long we should treat the patient, for how long at every session, based on the practical indication of the device, but as well on the information about saturation and efficacy. So if I have to somehow summarize, we need to identify the patient who possible benefit. If we need to start, we need to start probably early. Every speaker has mentioned the beneficial effect of starting early. We need to monitor inflammation parameter to make sure we treat the patient in the right way. And also, I think we need to treat the patient for a critical time, at least 3 days probably, because it is not one-shot disease. It's a condition that may develop over days. Very quickly, Professor KELLUM, do you have a practical recommendation?
Thank you, Claudio. I think that you've summed it up quite nicely. I think we should remember that this syndrome, this systemic manifestation of the disease, is not the typical response, but rather seen in a fraction of the patients that are critically ill with COVID-19. And early aggressive therapy in these patients is expected to influence their outcome. And so I think we're here today because we're interested in applying this sort of therapy to this subgroup of patients. And I want to thank all of our speakers and Professor RONCO, my co-moderator for this session, and the 300 plus attendees from around the world who've joined us today. I realize we couldn't answer all of your questions, but hopefully you found the presentations and the discussion to be useful. Thank you, and enjoy the rest of your day.
Thank you very much. Goodbye, everyone.
Thank you. Goodbye. Thank you.
Goodbye.
Thank you. Bye-bye.
Goodbye.
Bye.